President and CEO of the Jewish Healthcare Foundation and the Pittsburgh Regional Health Initiative. So welcome those of you who are here, who are involved with Liftoff Pittsburgh, and we'll tell you more about that after Michael's talk, and our Health Activist Network community, as well as Friends of Technology and Patient Safety. So for those of you who know me, you know that I've been working on medical errors for 20 plus years, and I see Ken Siegel here, who for a good part of that has been working with me. We've tried to find solutions over the years that would make a big difference in the outcomes of care, and we failed. So there was a query in the June 29th issue of The Atlantic by James Fallow. He asked, imagine if the National Transportation Safety Board investigated America's response to COVID. And it got me interested in the National Transportation Safety Board, about which I knew very little. And I was excited. I mean, their model, they come up with solutions to safety problems in travel. Prevention is a big focus so that errors don't happen. And most exciting to me, a lot of their solutions are autonomous. A lot of their corrective actions are autonomous. So think airbags, think of the anti-collision technology. So what did I love about that? Autonomous systems fix systems. They don't have to change behavior at the front lines. They don't have to work on culture change. And so my question was, is healthcare amenable to this? Could patient and worker safety be assured autonomously? Of course, I had no idea. So thanks to Wendy Everett, I got introduced to Michael McShea. And Michael has been the perfect person to help me answer this question, are we ready? And note that Michael comes from outside healthcare, which is, for those of us embedded, always a worthy exposure. He's a systems engineer. How appropriate, right? So Michael is a health systems innovation lead at Johns Hopkins Applied Physics Laboratory in the Next Generation Care Delivery Group of the National Health Mission Area. There are a lot of words in there, Michael, that we love. So we assume you're going to be taking us on a very worthy mission. He has a background in everything he should: cybersecurity, digital health solutions, mission critical infrastructure technologies, aviation, AI. I mean, he's familiar with all the right things. And I think you will see how valuable it is for us to get an outsider to look at healthcare and tell us whether indeed we could move toward more assured autonomy. So thank you so much, Liftoff. We'll tell you a little bit about Liftoff's next iteration in the exciting month of December, but that will come up after Michael's presentation. So Michael, go ahead.
All right, so can you see my screen, a large screen, not the presentation screen, hopefully?
Yes.
Great. So thanks, Karen, for that great introduction. And I think that, as I said earlier, before many of you may have gotten on, I'm actually quite honored to be able to talk to you all. I'm looking forward to your feedback. As Karen mentioned, I do have a lot of background in other industries, and I would call that like the first half of my career. The second half of my career has been in healthcare. For a good 15 years now, but based on all the other industries I've worked in, the whole premise here is that systems engineering and technology are available to really help improve patient safety. It's actually partly what got me into healthcare to begin with. And so you'll hear a little bit more about what shaped my views on that. I think it's important that you know where my point of view comes from, but it is very much from the standpoint of the practitioner of healthcare IT. Also, a few other disclaimers. Opinions are my own. I'm not endorsing any of the companies I'll talk about. I will talk about Johns Hopkins things, but everything I'm talking about is publicly available. And if you're interested in anything I'm talking about, please reach out to me afterwards for more discussion. So I want to get started with a few sayings we have at APL, or things that I've heard at APL first, I should say. They don't come all from APL to get us in the right mindset here. And it really is apropos, I think, for the discussion today. The first one is discovery consists of seeing what everyone has seen and thinking what no one else has thought. You know, and I think the premise there is that all the pieces are in front of us. None of us is as smart as all of us. And by that, I definitely mean not me, as smart as all of you and all of us combined. And I think that at APL, that's very much also the ethos. But my favorite is your job is to think. Jim Schatz from APL. And that's what makes APL such a great place to work. We were just named the #3 top companies, best places to work for innovation, right behind Google and well ahead of Amazon. But it's this kind of mindset that we bring. And so I was happy to take my mind to APL and try to harness all the really smart people and capabilities that were there. So Karen already covered why we're here. I don't think I need to dwell on it too much more. I think that, you know, depending on where you sit, you're either disheartened, outraged, or otherwise frustrated that we haven't made more progress in preventing medical errors, many leading to death. Around 1999, and 2001, you know, the works from IOM around this topic. And then more recently, you know, from Hopkins, actually coming up with a higher number, 10% of all US deaths due to medical errors, the third highest cause of death in the US. And, you know, Karen actually opened with another airline analogy in the swerve event that we had in DC earlier this year, which was the Boeing 737 MAX. And remember all the reaction to the two crashes within a few months of each other. And yet, you know, we still have the situation in healthcare where, you know, more than a 737 a day of people are killed by medical errors. And so in preparing for the swerve event in DC, I did a little homework and I looked at the ECRI, or ECRI if you're in the business and in the know, I guess, top 10 lists over the last few years. And one thing jumped out at me, and that is that so many of the issues could actually be helped by intelligent systems. And so that really got me thinking, and that got Karen and the folks at the Jewish Healthcare Foundation and I talking, and we've evolved our thinking about, you know, what this means for healthcare and what it means for improving patient safety. And I think the other key thing to recognize is that even though 20 years has gone by and we haven't seen a lot of improvement, and I should say, and I always want to say, that there are incredible things being done in healthcare by lots of incredible, passionate people and mission-driven people. And so this is not really a slam on any of them. But when you think about it, to err as human was before the HITECH Act. It was before we digitized healthcare. It was before 96% of health systems had EHRs. And it was before cloud platforms for the most part. We did have a different name for them back then. I'm old enough to realize that. But advances in machine learning and deep learning, and then regulatory reform, it's actually all pushing towards quality. So that leads me to first, the big, hairy, audacious goal. If you're a Jim Collins good to great fan, the goal needs to be to create a data-driven infrastructure to eliminate patient harms. And we do a lot of work with the military health system at APL, and we actually went back and forth with leadership on should there be a goal to minimize to a certain level of harms, and all kind of ended up with making harms a thing of the past, eliminating harms. And what would that mean? Think big. But I bring into this discussion a very practical point of view that really is kind of the theme of a lot of this talk, and that is that the technology already exists to do this, to reduce harms. And what we really need to do is take a more systematic approach to applying that technology to healthcare. Yes, there's some really good things to come, and I'll talk a little bit about that, but the reality is automation and artificial intelligence have been around for a long time. I'm going to speak from my direct experience here and a couple different roles that I've had. But I like to start with the airlines. People in healthcare tend to get a little tired of healthcare and financial tech analogies, and there's a financial tech one next. I'll give you a warning about that. But actually, this system really I find fascinating for a couple of reasons. One is that it was the source of so much automation in the airline industry. It was the major reason that they could reduce the number of pilots in the cockpit from 3 to 2, if you can imagine that. It's a global network that's like a global data cell network for airplanes. And the messaging that happens through it that automates the operations is so significant that really the planes would sit on the tarmac if these systems went down. And thankfully they don't, because of good engineering, of course. And that's not done with broadband. That's done with a whopping 9.6 kilobits per second. Remember modems with that? And so that's why, I always start there with the airlines. That there is automation, and there's a lot of artificial intelligence driving that automation. Not as sophisticated as what Karen was referencing earlier. And that's why, I think in this curve here of the Six Sigma curve from GE originally, I believe, shows that, airline baggage handling is really better than medication delivery. And that really just says that the technology is there. So that's exhibit 1. Exhibit 2, financial tech industry. I don't think I need to say a lot more about that. The interoperability and the integration is essential, but I can remember when I couldn't use all my credit cards at a gas pump or at a particular ATM. That all happened, and there was cooperation across the industry to make it happen for the good of all, which means it can happen. And I showed a picture of Mint here just because, it wasn't too long ago that I can remember manually entering my data into Quicken. Thank goodness we don't have to do that anymore. But also security, the same kind of concerns and challenges in financial services, and even satellites. I was involved with launching a couple of satellites back in the 90s for NASA, wind and polar missions, which had all these types of automation that I've listed here. That was quite a long while ago, and the reality is without this automation, you couldn't do operations of satellites. Daily uploads of command sequences, automatic actions, targeting and orbital maneuvers to hit a 2-kilometer square to get a gravity assist from the moon. I mean, those things were happening way back when. And I've listed some of the APL programs here too that are even more sophisticated. You've probably heard of New Horizons, going out past the end of the solar system. The communications are so slow, it has to have automation, right? And Dragonfly is the next big mission in one of the moons of Saturn that will have all kinds of navigation around it. And then cybersecurity is another example, I think, really to take to heart, given that there are billions of events happening that have to be sifted through to find anomalies. And when I think of the patient safety, I think of it that way. You're looking for the needle in the haystack that tells you that something needs to happen or something bad is about to happen. So what is the magic here? I mean, there's a lot of things these industries have, but more advanced technology. Remember, this is back in the 90s, and before the dot-com bust in some cases. Automation and machine-based intelligence, data-driven systems, interoperability, and the systems engineering to pull it all together. And so I would argue that we have most of those ingredients already in healthcare. I'm going to focus the rest of the talk on these 3 in the bottom. I think everybody knows what data is, and data is the new oil, or I guess for the healthcare industry, the new blood. But AI and automation are really the areas where I think that healthcare is lacking, and I think where the biggest stepwise improvements are possible. And I want to take a minute to define intelligence. We think of AI, and it's funny, at APL I hear people talking about AIs as things. It's like the AI did this, the AI did that. Well, the AI is really the brains in the intelligence system. That's the way that we look at it. And so what is an intelligent system? It's a system that can perceive, decide, and act autonomously, right? The really interesting thing about the definition that we have in our technology roadmap for AI, which I'll show you later, is the element of teaming with humans and in establishing trust with humans. As something that's essential for automation to happen in the future. That is future, but it is a lesson for us to think about. Doctors will not use the technology if it's not trusted. And then on the automation front, there's some very good definitions of that out there. And often we talk about it in terms of the SAE model for autonomous driving, autonomous cars, anywhere from zero automation to full automation. And when you think about this in healthcare, And anyone that's read Eric Topol's book, I think he puts healthcare down around 1 and 2 in level of autonomy. And his assertion, I think, is it'll never get beyond level 3. Well, we have projects at APL right now that are already trying to design level 5, which I'll talk about. But I would say that even moving up this ladder is going to have a huge improvement in patient safety. So I want to talk just a few minutes now about reason to believe. That is, you know, what things are happening in healthcare already that point to and again, from a technology standpoint, there's many advances in process improvement and care delivery that are outside of that. But what's happening in healthcare already that kind of resembles this model? And so I spent a lot of years originally at Eicu and then Philips Healthcare, being the product manager and product development lead for Eicu. And many of you may have heard of Eicu. It's the leading telecritical care system in the industry. And it basically lets one intensivist manage 150 patients with the same level of quality as if they were in the room. And I think many of you might know the Leapfrog study that showed the mortality difference between ICUs covered by intensivists and those were not. Well, this application, you know, has a lot of deployment and experience. It also has a lot of results in terms of improvements in mortality. But the thing people don't realize is it's a telehealth application, but it's not all about the video. The video is important. It's used in a different way than virtual visits. You're looking at, you know, reading the measurements on the trach tube, looking at the ventilator settings, looking at the medications hanging in the infusion pump bag, things of that nature, looking at the patient, looking at the pupils perhaps, the respiratory aspects. But it's really the AI that tells the clinician which patient to look at. And you see here, Mercy Virtual is shown as an example. You know, that's a fantastic facility. It's the hospital without beds, so they dubbed it. This is the doctor side, and you can see that they interact with the floor. It doesn't replace that. It has deployed it nationally and is expanding their deployments from 2 control centers in Cincinnati and Minneapolis. And you know that the VA is very advanced in telehealth and also patient safety. And Carolyn Clancy's been an integral part of Susan's efforts as well on Swerve. So what's the important thing to take away here? This is a look at the AI component, or a particular one. And I think what's important is, what's the automation here? The automation is telling the doctor which patients need to be looked at. That's not that they ignore everyone else. It's just that at this particular moment, who do you need to really pay attention to? And what we found is that integrating the analytics into the operations was probably the single most critical thing that actually created success, because it created a low tolerance for bad data and more trust in the technology. So that's one example. I won't go into as much depth in a few other examples I wanted to talk about just briefly, but you know, what I think is interesting is the control center concept of EICU is actually much more prevalent and broad at a hospital system level. And originally, you know, and IHI has some really good standards for this. It's all about patient flow. But what's being added to these control centers, and Hopkins has one, is more clinical capabilities, and they're becoming a center of telehealth. So this is really a good sign, because all the data is coming in, and I think that what remains is to decide to use it for patient safety specifically, which I'll get into more in a minute. Shenandoah surprised me. I was just up hiking by the Shenandoah Skyline Drive area. My wife broke her ankle, and we had a lot of interaction with the healthcare system during COVID that we didn't expect to have. I did not expect this kind of contact center and this kind of command center was behind it. And then just a couple more examples. Best kept secret at APL is the Essence system, which is built for the CDC and used in 47 different states. 73% of ED visits have information in this system. It's also used in the national capital area by the DoD. It's also the data that's behind the COVID map that we see on the news all the time from Hopkins. This is a platform that's built for all kinds of data inputs with a built-in platform for different types of AI that can be used, and visualization tools. And if you remember when Google predicted the flu season, where it was picking up based on Google searches, Essence beat Google by 2 weeks by looking at thermometer sales. But the point is, any data can go into the system and it's got a platform ready-made for analyzing that data. And what is it looking for? It's looking for patterns, it's looking for anomalies. And then, just to kind of punctuate the point, the data available is getting greater. The locations where care is being delivered is getting more diverse. And I had no idea what a meme this I've fallen and I can't get up thing is, by the way. Google that and see what you see. There's a lot of choices. But aging in place safely, we have to figure that out. Hospital to home applications as well, with more critical care being delivered at home. Remote patient monitoring is picking up, and certainly COVID is helping that. And virtual visits is something that a lot of people have been introduced to for the first time. The wearables and personal health tech, I just started using the Oura Ring myself. That's another one that you'll find an interesting result if you Google, because apparently someone wasn't happy with their Oura Ring and didn't have the thing you'd like to see sticking at you with that picture that came up first, but I used this one instead. The point is that we have lots more data to work with, and it's being used in different ways, and using it to protect patients, not just when they're in the hospital, but when they're out of the hospital is the key there. And sure enough, telerobotic surgery has adopted, the 5-step model, and there are really interesting projects going on trying to automate things like the Da Vinci system for various procedures that are actually even happening at Hopkins over at Whiting Engineering School. So that's the reason to believe. And why do we think we can do this? I think the answer is because we're already doing it in select places. And so I think the next couple of things to think about are what does this mean for the NPSA, the National Patient Safety Authority, which is the concept that was discussed at the SWIRV meetings that Karen and Wendy led. One in DC, one in Boston, and one in California. I think the California one had to go virtual, but we were together in DC. And the concept is really a good one, and I won't spend too much time, but I will kind of highlight, I think, the important features of the concept, because then we're going to talk about the technology that can make this happen and why it's a good time to try to do that. As Karen said, modeling it after the NTSB, I think, is a very wise way of looking at this. I think that ONC is a very interesting example for the kind of organization that can be created potentially initially independently, but more productively probably as part of HHS, where there are other regulatory arms to actually enforce compliance, so that the responsibility for policy recommendations and regulatory recommendations would come from the NPSA around patient safety, and the investigative power of being able to look at the data, find signals, figure out issues, and then actually address those with policy and regulatory recommendations. And look at this ecosystem, and thank you, credit to the Jewish Healthcare Foundation and Pittsburgh Regional Health Initiative for this incredible ecosystem map of all the different organizations that are trying to help patient safety today. What's desperately needed here is an organization to align all these efforts, and one that really acts as a touch point for all the discovery and innovation that's happening and how that folds into regulations with the ability to do research. And so what are the different pillars, if you will, then of the NPSA from a technical blueprint standpoint? So I think that surveillance is just a part of it. And I have here a model that was developed by Johns Hopkins, APL in cooperation with Johns Hopkins Medicine. You see Peter Provenost's name there, a big name in patient safety. This is a tiered interoperability model, and I'll come back to why interoperability is so important. But we think of things at the micro tier as point of care, the meso tier is the health system level, and the macro tier is across the entire ecosystem. The surveillance needs to be at the macro tier, but it needs to include a lot of information at the lower tiers to define what kind of issues are happening out there and detect the hazards that are happening out there. And so these three pillars of research and development, investigation, and policy and regulatory recommendations are what applies to the health system and the care delivery standpoint. Think of clinical decision support that is out there today, early warning systems driven by machine learning in many cases, sepsis detection, and things of that nature. If those could be formalized and made part of an expectation that if you have the data for those things, you are doing something with that data. That's the role of the NPSA. And then, I think that the first thing that really comes to mind that is a bit hard to get your head around is how is the NPSA going to get all that data? And, I like to point out that the health information exchanges, which are maturing and becoming a network of networks, and all the reporting infrastructure that's already in place for CMS are a good starting point. But the best model of all really is the Sentinel and FDA. They have actually created a whole infrastructure and governance process for access to data to define harms in medical devices that they can use, that they can then create the appropriate regulations and recommendations from without exposing the data or even in some cases, where the issues are. But I think that the important thing is the data, and there is a good precedent for this now with the Sentinel program. Just a real quick minute on interoperability, and I think that what is really important here is that it's a key enabler of autonomy, right? If you have so much work to do to the interoperability to happen, you don't have any money or time left to actually build the automation. There are lots of initiatives for standards and interoperability for these layers here up through the semantic layer. That's probably the last 10 feet, because I'm a telecom person, but that's still being solved. And certainly there's lots of technology that can help that. But what I find interesting in this model is this organizational interoperability concept. That, in my view, is a green field. How can we formalize that technically, and how can we use it to measure hazards? And I also like the Center for Medical Interoperability model, maturity model. I think what is interesting for the NPSA is that the ONC for the last 10 years has been focused on these elements of maturity and interoperability. I view the NPSA's efforts as really driving the next 10 years of what we're going to do with this data. And I think if you like Clayton Christensen, you know that innovation happens at the edge, right? It is the layer beyond the standardization. And so that we have to push that layer out. But I think that there's a really good set of frameworks out there that aren't tapped yet fully. I like the idea in safety engineering of risk-based metrics that are really trying to identify hazards before injury occurs. And there's a whole science out there around those things that I think is very applicable here. And then I think, in terms of tailwinds, CMS is actually helping here a great bit with the way they're viewing meaningful measures. And if you heard Seema Verma talk at the quality conference back in February, these are the 4 points that she made. They're actually from Becker's, but modernizing the infrastructure and analytics is one. What I really like is the way that she's tying safety to quality as part of the objective of meaningful measures. So that is what I would say are the tailwinds. The headwinds, we all know. And I'm not, as I said earlier, I'm a practitioner myself. I am not, it does not escape me that some of this work is hard, but I would argue that some of it is just work, and we need to get on with that work. And there's not new technology needed to do that work. I also think that the regulatory environment right now could not be better for what we're talking about. And I really would cite the 21st Century Cures Act and a lot of elements of that, anything from anti-data blocking, which is creating an API approach across the industry once it's rolled out, or will create TEFCA for health information exchanges, really kind of hopefully opening up the spigot for more data flowing across the network of networks, and pre-certification programs, which are a lot more friendly to building AI. I think standards efforts need to continue, but I think there's definitely plenty to work with to get patient safety really to get that stepwise improvement. I know I'm going really fast, but I'm probably still going slower than I need to make sure there's time for questions. So I'll go through this next section really quickly. But I wanted to also let you all know that the future is already being worked on, I think is the best way to put it. And I like to cite these companies here as, when I think about the future of telehealth, VitalChat is using computer vision to actually detect whether best practices are being followed or not. They're starting with e-sitter applications, which you may all be familiar with, looking at room traffic. There's other applications of computer vision out there looking at hand washing. And so there's some really interesting applications there. Bana Health is actually the first company I've found to have operationalized using video data to extract vital signs. Yes, heart rate variability, SpO2, respiratory rate, and blood pressure soon. Anura has done blood pressure by looking in your smartphone. So what does this mean? And then motive, of course, seems to have coined the term brainware. I don't have one of those yet, but it looks awful interesting. I'm not sure it's very stylish. The point of all this is that all this data is only going to increase. It's going to increase our ability to not protect patients from health issues, not just while they're in the hospitals, but outside the hospitals. And so the time is really now to build the infrastructure to support those applications. AI is another really interesting area, and I just found out that this roadmap of APLs is actually publicly released. You can guess, I don't have to tell you probably, that healthcare is in the bottom little kernel here, pattern recognition, right? Even though we know how to do it, we're not doing enough of it to actually prevent harms. But there are actually 4 different vectors of innovation here that are in work, and APL is innovating in these outer layers. The first is autonomous perception, that is ability to see what's happening. And actually, that's the seeing part before the act. Superhuman decision-making is certainly what we'd like doctors to have and we like to have for our own health. Human-machine teaming, though, is a critical part of this because not everything can be completely turned over to a machine. And then safe and assured operation. If we are turning things over to the machine, how actually confident are we that it'll do the right thing? And so that's what's coming. And then my favorite program to cite that is actually embodiment of a lot of that is the Medical Device Interoperability Reference Architecture. It's a project that we've been working on for over a year that really is trying to bring completely robotic medical care to the field. The reason being is the need for much longer survival rates in the field because of lack of superiority, air superiority or communication superiority. So yes, we are actually talking about robots taking care of you in the field and actually trying to figure out what the technology roadmap is for that. There's a great video here when these slides are sent out you can look at, that's 4 minutes. And then just to wrap it up, we also participate in the Institute for Assured Autonomy, which is really focused on how these things happen safely. The fact that APL is looking at these things means the technology is here. And now we're looking to make sure that it gets applied effectively. Not just the technology, but the ecosystem and policy around that. And you know, at APL, we deal with other things like weapon systems and defense as well. So it's really, really important to get all this right. And one of the flagship projects that we're actually in the process of defining is going to focus on healthcare. So I know I've gone really fast, and I hope I've given you at least some things to think about in terms of the technology being available to improve patient safety now. There is no reason not to be implementing this technology now to improve patient safety. There's some things technology cannot do anything about. And I say anything with a ... here, misaligned incentives and business model issues, regulatory constraints and culture. Okay, I actually do believe technology can help those things too, but that's me. But I wouldn't assert that that's the primary thing we should focus on. So I hope you found that useful, and I'd love to hear what your questions might be at any time we have left. And I hope I've left enough time for questions.
Thank you so much, Michael. It's a lot to take in and to consider. And we're going to take some questions now. So if folks want to enter their questions into the chat, and Karen is actually going to kick us off with a question here.
Well, we want to hear your questions, and I know some of you have them, but you also may have some ideas of the way autonomy and autonomous technology is being used in healthcare. So feel free not only to ask questions, but I think if you have some ideas out there that Michael and all of us would be interested in hearing.
We've got our first question from Tina here, and she asked Michael what your thoughts are on biased outcomes from AI and what are some ways to lessen this issue.
It's a great question, and it is one of the known weak points of the technology, but there are ways to address it. So, and what we're talking about here, I presume, is the bias is really, could have a couple of different sources. The most common thing we refer to there is the deep learning only works based on the data you use to train it. And so if that data is not representative of your patient population, or someone falls outside of the population that the AI was built on, it could produce bad results. And so to guard against that, you know, there is a discipline around deploying AI that really looks at the generalization of the technology. How do we test it to make sure that it's not overfitting, for example, or that it'll work on populations? you really need to test it a lot on populations that are diverse, but you also need to build it on populations, data from populations that's diverse. Also a need to manage the performance over time, and that needs to be continually evaluated. It's not set it and forget it. You need to reevaluate and see if your patient population has changed and that's affecting the accuracy of the algorithm. I would say that this is not terribly unlike, other systems, right? You tune the system, and then it has performance over time. That performance degrades, and you have to manage that. So it's very analogous to that in my view.
Thank you, Michael. We've got some more questions coming in here. So we have one, what are some skill sets for young professionals to focus on that they should gain in order to contribute to implementing autonomous technologies in healthcare?
That's a good question as well. And I think, I'll tell you what I tell my kids, which is make sure you learn about data. If there's one thing that you can apply just about anywhere, understand data, understand the complexity of it, understand the limitations of it, understand the science of how it's applied, and understand, how to look at outcomes from algorithms and understand their performance and things of that nature. So that, along with, a good dose of statistics. But I think I'm not an expert in the educational aspect of things, but I think that it is a general thing that I would say we should all think about. How do we make sure that in the medical profession, everyone that comes out of med school, it really understands how to use data?
Thank you. That's valuable insight. Another question here is, can you share your thoughts on the challenges and opportunities of integrating medical data with other systems of care?
Sure. So as luck would have it, I just spent, the last 3 weeks writing a white paper about this. It was very cathartic too. I got to write about all the things that were wrong with EMRs, but the reality is, we should be thankful that they're implemented and we have digital data. I think to the question, and I see there's questions around safety issues with EHRs as well. I mean, I think one of the biggest problems with EHRs is the human-computer interface. That's one of those technologies that I highlighted before. It wasn't in the box of what we're talking about today. But, the lack of ability of EHRs to deliver the right information to the right clinician that has a certain perspective about the right patient and their condition at this time can be dramatically improved. I think that data entry technologies will be a lot more about conversational interactions in the future and not typing. But, I think that probably the single biggest challenge that EHRs have is just from a regulatory standpoint, they really are prohibited from doing clinical decision support in an effective way. That's why you have to develop that technology yourself. And they may give you tools to deploy it in the EHR, but they cannot actually release it in the EHR because that would violate their Class 1 medical device status. And so because of that, you really need to think about technologies outside the EHR. The EHR will do the job that it's built to do. Well, some will say maybe it doesn't so well, but I think that, there's a lot of room for improvement. As far as integration goes, I think that to some degree I would put in the category of just work. What I'm really excited about is FHIR and specifically Smart on FHIR, because the EHRs, because they can't build that kind of technology, have really embraced FHIR as a way of getting data out of their system. And for those, there may be a lot of people familiar with FHIR on the call. I don't know if that's true or not, but it's really a rebranded HL7 version 3, I would say. It's a more modern API, a web service API to get data out of the system. Because anti-data blocking rules are driving implementation of FHIR to get access to data for patients, it's really going to cause, I think, a lot of activity in the coming years that makes integration easier to do. And I think we can all look forward to that. And the innovation that can happen on the data that's in the EHR will dominate, I think, in the next decade. And that's also where we could implement a lot of the patient safety technology that we're thinking about.
Kind of working off of this challenge of entering data, is it possible to map the known specific types of errors to the way the automation addresses it?
I'm not sure I heard everything that you said there. I'm sorry, Scotland.
If you want, it was my question. So I just wanted to ask, there's certainly been a lot of effort to identify the type of errors that are made. So we have long lists and so forth. Is there a way that one can sort of map those errors to how the automated system, smart automated system, sort of takes care of those problems?
So yeah, it's a very interesting question. And, I'm sure many on the call here have been through, Six Sigma kinds of efforts and things of that nature, process mapping, lean process design, and that sort of thing. What I think there's really an interesting role here for is system modeling. That is, systems engineering through modeling of the care process. And I think that's where a lot of very interesting fault tolerance issues can be exposed. But, I'm sure everyone knows failure modes effects analysis, which is a systems engineering technique to get to root cause. I think a lot of the techniques work, but what I think, and Mark, I don't have any kind of real magic suggestion here, but what we are looking at a little bit is how we model the system to find those problems and actually test out different approaches. You probably heard of virtual twin technology. Think of a ED department modeled completely, in digital technology from a system control standpoint with inputs, outputs, and control functions and so forth. You can test the system with different inputs and outputs, and from that, understand its performance and do optimization and things of that nature. So I think there's definitely a big role for modeling, system modeling. But any of those systems engineering techniques I mentioned before, I think are good. But I think you raised a good point here. Maybe it wasn't the point you were making, but if we're going to implement automation, this is where the assured safety comes into play. We are obligated to build those models to make sure we understand what happens when things go wrong, what happens when the inputs to the automation are unexpected. And that is a part of a systems engineering discipline, in my view.
Thanks.
We've got a comment here from David Klassen. Would love him to chime in and offer his insight on just the viability of predictive analytics. And he says there's some great current initiatives that can help support the NPSA approach. David, are you on to comment?
Can you hear me?
Yes.
Can you hear me now? Okay, great, sorry. So Michael, that was great, fantastic. And I think there's a lot of other initiatives we could add to this that would make an even stronger case for where we're going here. As you know, there are several initiatives around health systems in the U.S. coming together to automate patient safety measurement and management in real time, pulling data out of EHRs. And that approach has also gone to Australia and worked there as well. And that approach has been able to detect safety problems both as they occur, but also detect precursors of those safety problems before they occur, and then go a step further into predictive analytics and predict them as far as 3 days ahead of time. And so I do think, and that's with all the leading HRs, so with the current state of interoperability, this approach works because you're exactly right. HL7 Fire is merely just a later version of HL7. We've gotten far enough in HL7 interoperability that you can pull an incredible amount of data out of the EHR and use it in real time. And this sort of real-time measurement and surveillance can be used not only to help healthcare workers detect and reduce harm, but through a project Robert Wood Johnson funded us, we actually gave real-time safety event information, precursor information, and then predictive analytics to patients and their families, let them see it in real time in dashboards, not only in the hospital, but on their cell phones and on their iPads, et cetera. And what we found is patients really took to it. It didn't scare them, and it reduced 30-day mortality and readmissions. So I think there are a lot of initiatives that we can point to already with the current state of interoperability where we can say that this automation approach can have a major impact tomorrow if we wanted to.
So that's even better, David. I mean, I'm talking about analogies here in some cases, but there's real activity going on in this space. And that project in particular, can you just elaborate on the kinds of harms that you were looking at? Is it?
Yeah, so basically that project tried to look at the broad array of harms that we developed when we developed the trigger tool at IHI, the global trigger tool that we developed in the early 2000s. And this project was to automate that, basically. And it took a lot of iterations to get all the noise out of the system and reconfigure those manual triggers to electronic ones. So it looks at all types of harm, from surgical misadventures to medication-related harm to nosocomial infections to falls to pressure ulcers, etc. And it turns out you can detect about 90 to 95% of that harm with about 55 automated signals out of the EHR combined with a infection control surveillance type program. And that can be done, Michael, not only at the ward, at the hospital level, it can be even done at the national level. So a version of what you were showing in terms of a command center.
That's fantastic, David. And I think that's wonderful to hear that those kind of things already exist. And I had not heard of that one in particular. But I'll tell you that this is exactly why, we think that it's time for the NPSA to be established. Take those kind of and really drive them and scale them nationally. And I'd love to talk to you more offline about what you're doing along those lines, because it's fantastic that you've already made that much progress. And I apologize, I was not aware of that. I would have referenced it earlier.
Well, I should have sent it to you, but there's one other thing we're doing, Michael. We're deeply involved with the DoD and the VA in a weapons lab program to extract meaningful, useful data from the EHRs in real time. So much along the line you were just referring to is already going on. It has been for about 3 years.
Fantastic. And I think the weapons, I'm not sure what the weapons reference there was, but when you think about
weapons labs, the big weapons labs are involved in this.
If we are, turning over this kind of automation, or some of it at least, guided to defense, for example, and for superhuman decision-making, we ought to be using that technology in healthcare as well, clearly.
Absolutely.
Thanks for that, David.
Thank you. The only other thing I would say, Michael, because I see the comment about operating losses, it turns out in some of these big health systems that track all-cause harm electronically, they find 10 to 40 times more harm. But when they cost it out, many of these health systems are absorbing the cost for those harms themselves. Because they're taking risk. So it turns out that safety might be a really big business case in terms of cost saving.
So I think you're right on that point, and I really do think that value-based contracting is going to also be a potential source for driving patient safety initiatives from that perspective. Because you can't, if you have the data, you can't afford not to use it to avoid these harms, which are very costly in practice, but in complications and on unpaid care and things of that nature. So I think that's a really good alignment on that front. And I do believe in the cost of safety is similar to the cost of quality, right?
And one big health system, which was an HMO, showed that the safety cost in the hospital was less than the 1 year downstream safety cost afterwards. So temporary harm was not temporary. It haunted the patient for a year afterwards in increased outpatient costs, et cetera. So you might be able to make a huge business case for safety if you look at the whole episode of care beyond just the hospital.
Thanks for that, David. Thank you. That's great. And that may speak to Deborah Thompson's question here, where she was asking me about the systems that are struggling with significant operating losses at the moment, and how to create momentum forward to support these innovative strategies.
So yeah, that's a great question. I mean, I think it was Carolyn Clancy at the SWIR event and in a subsequent conversation that really has brought up the point that COVID-19 in particular has kind of exposed some of the challenges in the system, and should be, even though it's very painful financially for a lot of health systems, potentially an impetus for, improving operations along those lines. But I do sympathize with the challenges that are going on right now. And I would only say that and I do believe this, but I'm not an economist. I'm a technology person. I do think that it's one of the situations where can you afford not to take care of this, and what are the costs that you're actually absorbing, as David pointed out earlier, that are not being taken into account. In any case, I think each health system situation is probably unique. But still an initiative worth starting.
So, Michael, I'm very curious. As you know, I'm fascinated with Madeira. So, battlefield, mass casualties, yes. What if you put Madeira in a nursing home or in a hospital, and it could respond to a rapid response team crisis? We call it Condition C. Some of our hospitals here in Pittsburgh. But I mean, does it have to be limited to battlefields and mass casualties?
So I think, that's a really interesting long-term question. I mean, if you saw our AI roadmap, and someday soon there'll be an equivalent robotics roadmap along those lines. You can certainly envision that kind of future. The Madeira actually, though, does have civilian applications that are already defined for disaster recovery and response. So when you think of like a national disaster or even a mass shooting like that happened in Las Vegas, how can you leverage automation and robotics to save lives? So there are actually first responder oriented applications already being thought about. But I like the future you paint. I mean, I think the one that I'm even more fond of is a healthcare assistant that keeps you from getting sick to begin with. And that's another aspiration that we have, long term. That would be even better, right?
Thumbs up.
Ken, I know that you had a question that Michael addressed a bit. Did you want to kind of elaborate on that any further? Or?
Sure. So, Michael, I had the question that was getting at, we see sort of obviously all of this promise in technology, and yet healthcare as an industry still seems behind in how it works with technology, and sometimes it sort of freezes improvement because it's hard to make changes rapidly given how the industry tends to deal with improvement queues, et cetera. And I think I heard you saying the EHR, because of its nature and some of the constraints, is not the place to look for more rapid innovation, but it's what plugs into it. But are there anything that other industries that have gone further suggest as the next important steps so that healthcare can improve its capacity, maybe at that middle layer, that system layer, to work with technology to get the most out of it instead of sort of getting stuck in the parts that are difficult with it?
So I don't know that I have a great answer to that, Ken, or an analogy for it. All I can say is that, a lot of the technology projects that I've been involved with over the last 5 years, at least, and maybe longer, have focused more on, not on improving the enterprise systems, but on improving the ability to capture the data from those systems and building platforms for innovation on top of that. And I think it's really interesting how, how archaic some of the systems are that we work with. But if we get the data out of them, then, and free the data, let's say, a lot more innovation is possible. And I think that's what you see, especially when API-based integrations like FHIR really getting traction and making it easier and easier to get data out of the system. It really unleashes a lot of innovation. And now you have anti-data blocking, which requires health systems to enable that data to be accessed. And I think the implementation timeframe for that is the next 3 years. So I'm not on EHRs. Like I said, we should be thankful that all the data is digital. But it would be a pretty big re-architecture of the EHR as a system to do this thing. I think that's pretty well understood. But anyway, I'm sure there are also examples of lots of incredible innovation happening with EHRs, and some of them are highly flexible if you invest right. But for a fast-moving, more agile innovation front, I think the EHR becomes a place to get data from. So anyway, I don't know if I answered your question, but I would say that solving that kind of problem is not unique to healthcare. There's a similar thing going on in many other industries, I would say.
So we're
Busy systems are underneath sometimes. Sorry, Karen, go ahead.
no, I was just gonna say, I think we're coming to the end of our time. Am I right, Maren? So, Michael, this is terrific. And as you know, we will definitely be continuing the conversation with you, but there are probably people here who would like to do so as well. In fact, Robert and Maren and I were talking to people before this, and they wanted to get in touch with you directly. I would love to say that the National Patient Safety Authority may be an idea whose time has come. So if James Fallow asked, what if the NTSB had investigated COVID? I mean, we know things would have happened differently if there were an organization like a National Patient Safety Authority. Supplies and tests, equipment, expertise might have gotten to the right place faster and in a more directed way. There was no central distribution point. There's so many things that we can imagine that aren't only related to autonomous technologies, but also just policies that lead to behavior change, just the very good solutions that come out of the NTSB. That's what it's here for. So whether it's raising the drinking age to 21 to prevent accidents from drinking and driving, or setting clear standards for school bus construction, there are things, so many things that are good solutions that don't get applied in healthcare. And I know, looking at all the people on this phone, you can all name 100 of them, but they sit out there and they don't get applied. So we really want to hear from all of you. September 17th is World Patient Safety Day, and the Patient Safety Movement Foundation is having a virtual summit. So there's a link in the chat for details. But we're going to be doing more and more and focusing on this issue. So we do want to announce that Liftoff Pittsburgh will be taking place over the month of December with an incredible lineup of demand and live programming in a highly interactive, virtual, live, 2-day broadcast. So mark your calendars, December 15th and 16th, and visit our website to get more detail. But we do want you to join us, but we also want your ideas so that our programs on those 2 days meet a lot of your needs. So I'm very excited, Michael, that you are here today. You give me hope. I think that there's so much more we could do. And some of it is exciting, and some of it, for those of you in the startup world, I hope you're listening. I think there are business opportunities here. Unfortunately, the space is wide open. And yet I think, you know, if we only focus on changing human behavior and changing culture, we may miss a lot of opportunities. So as I tell Michael often, I keep thinking, Michael and the Applied Physics Lab work a lot with NASA and on space travel. If we can predict all the things that could go wrong to get someone to the moon and back, if we can have a whole panel of experts sitting in their control room, fixing hot spots before anyone gets harmed, we can do this in healthcare. We can bring it right down to the hospital and maybe practice level. So we'd love to hear from all of you. Michael, I can't thank you enough for the inspiration you give us, that progress is possible. And I do want to take a quick moment to thank my friend Wendy Everett from Knee-High, who has been our partner in this whole exploration, this whole journey that would lead to an NPSA that could really be powerful. So thank you all for tuning in. Michael, I do want you to know you do have people here who could make a huge difference and make a huge difference in our community. So,
Yes.
you know, may the force be with us.
Thank you so much for the invitation, and I'll look forward to engaging outside of this presentation with anyone that would like to reach out as well. Thank you.
Well, you know, you'll never get away from us. Thank you so much, everyone.